Good evening, all, and thank you, Ni, for this session. So, diabetic retinopathy, because of its significant impact on our society, it is one of the diseases which need actually a definite algorithm for management. And the worst thing is that it affects usually uh, men in their most productive age group, thereby causing a significant morbidity to his family as well as the society. Challenges are mainly due to unlike other diseases which we talked so far, this is having lot of comorbidities, systemic problems, and again the treatment response, whatever we have currently today in our armamentarium, the treatment response is very unpredictable, and compliance also for these patients very poor. So this will be a broad outline how you manage a case of diabetic retinopathy. First is an evaluation of the disease based on the systemic as well as ocular biomarkers. Biomarkers does not mean just the imaging biomarkers, but the systemic condition of the patient. And based on this, you form a prediction how this patient is going to respond and what treatment is going to be best for him, and then form a treatment plan and proceed with the treatment plan. But as I told earlier, there are a lot of unpredictabilities in management of diabetic retinopathy. So each time reassess and see is it going as per your plan, then be ready to change your plan at any point of time. So the main thing as soon as a patient presents to you with diabetic retinopathy is evaluate the predominant stage of the disease. So you look at the macula, whether there is a diabetic macular edema or not. If there is a diabetic macular edema, look at what is happening to the background retina, because background retina can be ischemic or non-ischemic. Non-ischemic means mild and moderate DR where there is not much ischemic changes happening in the background retina. Whereas very severe NPDR or PDR, there's a lot of ischemic process going on. The response to treatment for diabetic macular edema is going to be totally different in those patients. So if you have a mild, moderate NPDR and DME, go ahead with your routine diabetic macular edema protocol. But if you have a lot of ischemic changes, remember that you still go ahead with DME protocol. You keep on injecting, but always remember that this patient's DRSS score or the diabetic retinopathy severity score keeps on decreasing as you inject, and you may be falsely led to believe that this patient is having come down to mild or moderate NPDR, whereas actually the ischemic process is still ongoing. And once you stop DME protocol or your injections, then you should be prepared to treat this patient with panretinal photocoagulation. And then the next set of patients where it is more severe, where they have a lot of tractional risk, then there your priority becomes to prevent this patient from going blind rather than improving vision. So there you start again with your panretinal photocoagulation in not in the normal pattern, but in a fractionated pattern or a modified pattern, so that PRP does not worsen the traction. Then you treat the residual macular edema or worsened macular edema, whatever is present. And PDR with no diabetic macular edema, then you start doing with PRP. But remember that many of the patients, at least 25% of the patients, do develop macular edema when you start with PRP, and you will have to treat those macular edema as per your diabetic macular edema protocol after you complete your PRP. Then comes the surgical complications, which allow to be dealt with surgery. We'll just briefly go through the scenarios that we'll have. And as I told earlier, it's important to evaluate the systemic biomarkers that are present, which will tell you what is going on and how you have to interfere in this particular patient. So these are many of the patients who may be on drugs like glutathiones, can have chronic macular edema, refractory hypertension, and many of the diseases like CKD can mask the diabetic changes because of the anemia as well as arterial attenuation that happens. You may not see actually what is happening. And some of the diseases like leukemia or blood dyscrasias can actually accentuate the diabetic changes that we see more than what is actually due to diabetes. And coming to the ocular evaluation, other than the diabetic retinopathy, what you have to look at is what is the lens status. Is the patient aphakic, pseudophakic, or is there a cataract with poor view of fundus, or cataract with a laserable fundus view, or a treatable OCT doable fundus view? Is there a glaucoma? If it is present, is IOP controlled on medications or not controlled? Is there a rubeosis, or is it a post-vitrectomy status? And then comes our imaging part, where you do the imaging is mainly aimed at looking at three things. Is there what is the amount of ischemia that is happening? Is the disease chronic? And are there biomarkers of inflammation? So imaging biomarkers are not well validated, but still we have an idea. So you could do FFA is first of all most required in a case where you have unexplained vision loss, which will detect a distorted foveal avascular zone, or also you can make out this focal leaking microaneurysm. In these patients, it is a good prognosis. Usually you can do a focal laser also once you treat the macular edema with injection. And this kind of appearance where there is a diffuse leak on FFA shows an ischemic or an inflammatory biomarker. They may be poor responders of intravitreal injection. And FFA is also useful in non-responders to injection where there may be some lesions like retinal capillary macroaneurysm, which can be treated with focal laser, or you can FFA is again useful to identify the masquerades like macular telangiectasia, or as well as where the fundus view is blocked due to asteroid or cataract. And also FFA is useful in some cases what are known as featureless retina, where you see these small sclerosed vessels in the peripheral retina. There are no other diabetic changes, so it is better to do an FFA in these cases because you might otherwise miss a neovascular process that is happening. And OCT is the most important tool, and here it is very useful for treatment decision making to decide whether it is a center involving, non-center involving macular edema, when we have to look at prognostic markers to look at the treatment response and identify resistance as well as recurrence. So OCT will tell you whether there are markers of inflammation like HRF, which are high refractory foci. These patients may be a better responder to steroid, or chronic signs like this disappearance of these bridging retinal processes and this is becoming degenerative, or the drool or the disorganization of retinal outer layers or disorganization of retinal inner layers. All these are markers of chronicity which will help you to prognosticate the disease. So coming to the TME, diabetic macular edema protocol, it is like if you have a non-site threatening, non-center involving DME and vision is good, you can observe this patient. But if there is a parafoveal fluid which is causing a symptoms like metamorphopsia, then you can treat it with focal laser if there are treatable microaneurysms there. Center involving DME with good vision is good, then the studies show that even it is they can be observed, or most of the patients do well with observation alone. Injection is only required if there is a drop in vision or there is a worsening of macular edema. Then you have the center involving DME. Here we usually follow the drcr.net protocol where you inject monthly for 4 to 6 months till you get maximum improvement in macular edema. Macular edema, if it goes completely well and good, you can stop injection. Otherwise, once after 2 injections still there is no improvement, then you can stop injection, withhold injection, see what is happening. If the macular edema is recurring, then again you have to go back to your injection protocol. And DME sometimes persists after maximum injection has given. Then what do you do with this persistent DME? You have stopped injection, now what do you do with it? You have 2 options. If there are visible microaneurysms, or if you see fresh cercinates, or you see a leak on FFA, then you can treat with focal laser to those lesions, which might prevent the recurrence of macular edema. If there is nothing visible, or if there is a hard subfoveal clump or plaque, then those patients can be observed without further treatment. And recurrent DME, a case like this where it has responded very well, completely gone back to normal, now recurs. What will you do? Here it is better to restart treatment with the same drug that you have used before for treating the macular edema, because it had responded previously also. No need to switch. But then there are group of patients like this, they are not at all responding. You are not getting even 10% improvement in macular thickness. Then what will you do in these cases? Or sometimes as this case, it can be even worsening after intravitreal injection. So in these cases, these are known as non-responders. There are various definitions, but in real world, you would inject 2 or 3 injections and still you are not getting the satisfactory response, then you it is better to switch drug to a different class from anti-VEGF to steroid in those cases, or you can even switch to another anti-VEGF, but better maybe to switch the class. And always it's important you review the systemic status of the patient. Has the BP fluctuate? Is the BP of the patient fluctuating? Any new drug has been added to the treatment for systemic disease, or you may have to check the complete hemogram of the patient to look for any blood related malignancies also. So when do you consider steroid? So if you have a patient who is having a recent history of thromboembolic event, CVA or IHT, or if the patient is pseudophakic and it has reached a plateau phase with persistent intraretinal fluid, and if the patient requires cataract surgery, then these are ideal candidates for straight away starting on intravitreal steroids. And post vitrectomy eyes, definitely the choice of drug is steroids. And if the patient develops any epiretinal complication, or if there is during the course of injection, then you can consider vitrectomy. And patients who are undergoing cataract surgery, it's better to combine with an intravitreal. If there is macular edema, better to combine with intravitreal injection, preferably a steroid. And post cataract surgery, you can have 2 things. One, there can be a worsening of the pre-existing macular edema due to diabetic macular edema, or it can be a pseudophakic DME. So here it's very different because the treatment is going to be totally different. So it is very important to differentiate these two. You can use clinical clues as well as angiography. And just 2 more minutes only. So DME with PDR, start with anti-VEGF DRCR.NOT protocol, start treating the DME, and PRP you should never forget to do before you stop injections. But as I told earlier, if there are large predominantly vascular and new vessels, then you better start with a fractionated PRP, then complete with complete treatment of the DME. Post PRP eyes, it's usually very recalcitrant to treatment for any intravitreal injection. Steroids may be a better option in these eyes. And systemic factors always control, and that's a final algorithm for DME management. So first look at the ophthalmic factors and decide if it is PDR, then it is first line. If there is a PDR associated with DME, then it's first line anti-VEGF. Vitrectomy is right, it's first line dexamethasone implant or tricot. If it is ischemic, anti-VEGF or both are going to be poor, but maybe steroid may be better. Inflammatory biomarkers, if it is better, present, if then steroids may be better. Tractional edema, then first line is vitrectomy with intravitreal steroids. And if IOP is controlled, you can, if glaucoma patients, it may be better to go for anti-VEGF injections. And so looking at systemic factors, if the patient is having either pregnancy or recent thromboembolic events, then it's better to go with intravitreal steroids. And patient, if they are not compliant, if they are not, especially the Gulf patients, it's better to go with steroid implant. And coming to PDR, if with no DME and no risk for traction, go ahead with standard PRP protocol. And if there is risk of traction worsening, then do a fractionated PRP. You avoid doing around the new vessels and do small sittings, 300, 400 burns, so that you don't worsen the traction. So these are the patients who are actually this kind of new vessels. If you see highly vascular new vessels, this, if you inject for macular edema, this can undergo the angiofibrotic switch, which will cause severe macular traction suddenly. So these patients are ideal candidates where you should do a fractionated PRP first and then treat the diabetic macular edema. Then, even though there are a lot of studies which shows anti-VEGF as primary treatment of PDR, we are not yet, due to various reasons, we cannot adopt it right now. So we can use anti-VEGF as adjunct in PDR. You have a mild vitreous hemorrhage in an eye which is showing a small neovascularization, you can inject and then do PRP once heme resolves, or if there is a PDR with cataract, again you can do injection followed by cataract surgery followed by PRP. And if you have maximum lasered eye like this with new vessels still persisting, you can do an injection which will regress the new vessels. And already fibrosed tractional bands with mild bleeds due to traction component, you can, if the patient is not especially fit for surgery, you can do an intravitreal injection. And advanced diabetic eye disease, of course, vitreous hemorrhage, combined retinal detachment, tractional detachment, and neovascular glaucoma, these are indications for vitrectomy. So to conclude, in real world scenario, diabetic retinopathy treatment remains suboptimal. So an algorithmic approach can deliver judicious treatment to these patients who are facing blindness. Thank you.
Thank you, Prakash. Just one question, quick question. Practically in your clinic, how close do you look at OCT biomarkers while deciding treatment or retreatment and all those?
Primary treatment, I am not actually looking much at OCT biomarkers. Most of the time, unlike if the patient is not having any thromboembolic event or anything, I just go ahead with anti-VEGF as a first line of treatment. So I may not look at the biomarkers because I am not yet convinced about the role of biomarkers.